Well, hello, everyone. It's great to see you all today. Thank you for joining us. We have a small but mighty group with us this afternoon, evening, nighttime, or maybe morning for you. For those of you who haven't got a chance to meet yet, my name is Jack. I'm one of the CP Solvers team members, and I'm just super excited to get to do what we get to do here every day, which is hopefully hear a great case, think through medicine, and get to do some learning together. I am over the moon to get to share with you all who I had the chance to co-facilitate with today. I'm going to turn it over to the one and only Vale, who will be facilitating with us today. Vale, how's it going?
Hi, Jack. Thank you so much for that introduction. Yes, I'm Vale. I'm calling from Lima, Peru. It's the evening time here. And yeah, it's one of my first times facilitating, so I will try my best, and who better to do it than Jack. And I'm really excited for the group that we have today. And so I would like to call everyone, if you have a case, we would love to hear it and discuss with you all. And I think maybe I can turn it over to Kelly and Deborah that are the team today as well, that are helping us with the scribe and teaching points to introduce themselves too.
Hey, I'm Kelly. I'm a fourth year at Lee Comp Bradenton, and I will be your scribe for today.
Hello, everyone. I'm Deborah. I'm from Brazil. I'm a medical student, and it's night here. I just got back from CrossFit, and that's it. Let's go for it.
As people scroll through their case logs for a case to present, one of the things that I've been trying to do more and more often is to just ask, is it anybody's first time coming to VMR today? I see a lot of familiar names, but if for anybody, is this your first time here with us? Second time from Sylvia. Sylvia, second time, just as good, if not better than the first. Sylvia, if you're in a place where you are able to unmute, I know that we would all be thrilled to learn a little bit more about you and what brings you to VMR. Totally okay if you're not in a spot where you can talk.
I just want to say that I love your picture, Sylvia. Is that your puppy? So cute.
Well, again, we will put out another call if there is anybody who has a case. We would love to get to learn and talk through your case.
Yeah, and maybe while we wait just a couple more minutes, I maybe can reflect on yesterday's case.
Yes.
It was neuro VMR, which is one of my favorites, and we had actually a neuro ID case without spoiling much of it. But so it was a patient presenting with seizures that didn't really have any focalizing signs or symptoms. The neuro exam was pretty normal and had a past medical history of sickle cell anemia. And so we quickly, because we were discussing with Hans, jumped to think about maybe an infarct and a stroke, just because of the past medical history, but we totally forgot. And that's kind of my big reflection, was that I was totally biased by that past medical history. I totally forgot about kind of my initial bias, which is thinking about infectious diseases, and especially with a young patient presenting with seizures, thinking about some parasites that here in Peru are pretty common, and it's pretty like, I will probably, if the sickle cell part wasn't there and it was here in Peru, I probably would say, okay, this is neurocercosis right out the way, out the gate, but it was not the case just because of that bias. And it was a case that I think you would have liked, Jack, because it was an implication of the analogy that you always say, the one that of the pen rolling through the table, and kind of a subacute chronic thing going on in the nervous system and presenting quite abruptly. And so really recommend it. And does anybody have a case?
And to continue to practice comfort with silence. Any case is a great case. And if we don't have one, sometimes we have one in our VMR folder case logs, although we may be missing the people who have access to that.
No, I was just looking for it. I think I can send it to maybe Kelly or Deborah if you don't have it. It's basically the human DX cases, so I'm gonna share it with you.
Yeah, maybe that's a great idea. Deborah, maybe so that Kelly can scribe, would you be up to present the case aliquots and then also do the teaching points, Deborah?
Yeah, I can do it.
Thank you. All right, well, while we get the case set up, I think, Vali, the point that you brought up there, I think like that teaching pearl of how acuity of symptom onset doesn't always map onto the acuity of the underlying pathology is like a universal one, which is that like our brains will oftentimes try to map on something that led to the cause of any sort of symptoms. And so individuals might say like, oh, this abdominal pain started after I had lunch, but it doesn't necessarily mean that the cause of the abdominal pain is the meal that they just ate. We just try to link our symptom to something that happened in our lives. And so oftentimes that means that we have to sort of move through two separate but parallel pathways, which is that like this is an acute process, as in the case yesterday, that just started when the symptoms started, or actually this is a process that has been going on for some time that we're just becoming aware of when the symptoms started. And it sounds like in yesterday's case, we won't reveal the final diagnosis, but in yesterday's case, it was maybe the latter.
I don't know if, yeah, totally agree there. Sorry, just I wanted to know if maybe Deborah, you have the Human DX app, because I think the cases, you can only access them through the app. The ones that together. Okay, perfect.
It looks like Robbie has a case. Robbie, you've been holding out on us for 9 minutes. I will forgive you. And we are so excited that you have a case.
Sure. It's a very simple case.
No such thing. No such thing for me. All cases are difficult for me.
Speaking of abdominal pain after having lunch, that's the when you said that, it reminded me of a case.
Awesome. Well, yeah. Kelly, we'll let you take over the whiteboard, and yeah, Robbie, feel free to take us away on the case.
So 35-year-old female presented to our hospital with abdominal pain. Moreover, HBA. So the abdominal pain is located in the epigastric area. It got worse after eating her lunch. And she rated the pain 10 out of 10. It woke her up from sleep. The abdominal pain was associated with nausea, vomiting. And there's no blood in her stool, no diarrhea. And this is the first episode she experiences abdominal pain.
Is that a place for us to stop, Robbie?
Yes.
Vale, I will turn it over to you to take us away with how you're thinking about this young woman with new acute abdominal pain.
Yeah, I think, well, first is a young woman, and I think some red flags that I find in this is the fact that it's very, very strong, the pain, very painful, and also that apparently it's very acute. I'm not sure, I mean, if it's a 10/10, I would expect it to just be very, very abrupt. Can you hear me? Sorry, I think I froze.
I can still hear you.
Oh, okay.
Yes, we can.
So yeah, I think. Okay, thank you. Thank you. My work. Think about ruling out a cardiac cause that is just irradiating and could explain it, but the fact that it's a very young female makes it less likely. But even but just that as an emergency cause, I would like to rule it out. And also other like very, very urgent life-threatening causes could be a perforation. And in a female, considering like an ectopic pregnancy, even though that the location would be unusual, the fact that it's associated with nausea and vomiting and it's related to the food after eating lunch, I would like to know maybe there's an obstruction and the characteristics of the vomiting, if there's bilious or not, and how are the vomiting pattern in the sense if it's explosive or not. That could also make us think about maybe not localizing in the abdomen as much, but even in like if you have explosive, it could also indicate like increase intracranial pressure. And so I think that's where my mind is going, to rule out first the life-threatening causes, perforation, an MI, an ectopic pregnancy, and then to localize in the pancreatic region to think about things in the duodenum and maybe even the biliary system as well.
Well, I think that's an absolutely brilliant start, and really taking us through a head-to-toe initial framework in our approach to abdominal pain. I think is not only fantastic reasoning, but also completely appropriate, because as you mentioned, the severity of the pain is quite high, right? If we have abrupt onset 10 out of 10 abdominal pain, that could be something that we may end up discovering isn't severe, but we have to treat it as a severe and potentially catastrophic problem off the bat, given that there are so many potentially terrible diagnoses that can manifest as acute abdominal pain, including processes that exist in the abdomen or processes that are actually existing primarily outside of the abdomen, like a cardiovascular cause, or in rare cases an intracranial cause, as you mentioned. I'll talk briefly about sort of how we can maybe reconcile the dilemma that you kicked off our entire conversation today with, which is like what do we do with the fact that this is pain that's worse after eating? And I think it can be tempting to already start to anchor this into a postprandial abdominal pain framework, which the sort of categories that I think about when we are dealing with specifically postprandial abdominal pain would be pancreatic causes, as you mentioned, Vale, hepatobiliary causes, as you mentioned, luminal causes, whether that's an obstruction or an intraluminal process, or in certain cases, vascular causes, whether that's something like mesenteric ischemia, or in much less common cases, an underlying vasculitis, right? It can be tempting to sort of anchor ourselves into that space. And I'll be honest, many of the things that lead somebody to develop abdominal pain get worse when we put things into the abdomen, like food. And so I think at this point, right, we may sort of work these up in parallel, treating this as a general abdominal pain case and thinking about all of the potential causes, whether it's the epigastric causes like the stomach and the pancreas, or a potential atypical presentation of things that may often present with lower quadrant or pelvic pain, depending on what this individual's pelvic anatomy is. So I think we have to really sort of treat these processes in parallel up front, thinking about this as severe acute abdominal pain in general, and ruling out the can't miss causes like a vascular catastrophe, ischemia, perforation, or an acute obstruction, and then also working up specifically the postprandial bucket with maybe a little bit more focus. And again, that's going to be luminal, pancreatic, hepatobiliary, or vascular. How can we potentially prioritize these in somebody who is young? I think in addition, right, the likelihood of chronic mesenteric ischemia or an acute non-inflammatory vascular cause is probably a little bit less likely, because that's usually going to be related to the development of atherosclerotic disease, which again will take some time for an individual to develop and usually happens after 35 years. However, those sort of small probability changes pale in comparison to the urgency with which we have to treat somebody who has acute onset abdominal pain. So I think at this point, nothing is really going to be off of our list until we get a more thorough evaluation with the exam, and depending on how things go, potentially imaging. It's totally plausible that this is a very common manifestation of a relatively benign abdominal condition like viral gastroenteritis. The fact that this case is coming to virtual morning report may change the probabilities there, but in reality, we're going to be thinking about sort of the whole gamut of anything from benign acute causes to the potentially severe causes, and really it's going to be vitals, exam, and labs that's going to help us risk stratify which of those severity categories we're dealing with.
I love that, Jack. And I think also maybe something that we hadn't talked about just yet, Jasimra mentioned in the chat. I don't know if you want to share your thoughts on musculoskeletal origin for this pain too.
Please excuse me. I don't know why I took it as back pain, and my first thought just went towards the back pain, but it's clearly written abdominal pain. I don't know, sometimes it happens. And I was reading it as like back pain, and I was like musculoskeletal region. And then you start talking about the abdominal pain, I realized it's abdomen. So, but definitely whatever you guys told regarding the vascular region, perforation, the chest, the cardiac causes, we have to take those into consideration.
No, but I love it actually, because I mean, it has happened to me. One of my best friends actually came thinking that he had an MI when he just had a musculoskeletal strain in his chest. And so the epigastric region pretty close. And actually what I thought when you said musculoskeletal was also the skin, just thinking about, for example, shingles and herpes zoster, which can present the neuropathic pain, can precede the rash or the vesicles that forms the virus. And so could it be like this super abrupt? I'm not sure, but definitely thank you, Yasimran, for putting it in the differential as well.
There was a patient that came to the OPD and she has like right quadrant pain, and it was, we came up with certain causes, but it was actually just myofascial pain. So that was diagnosed as myofascial pain in outpatient department. So I remember that thing.
Fantastic. I love it. Ravi, would you be up to take us into the second aliquot here?
Yes, on the review of systems, so she had no fever, no cough, no chest pain. However, she said she developed shortness of breath because of the pain was so severe that caused her to have short of breath. And she never experienced this kind of epigastric pain. This is the first episode. On the day of admission, she also said she threw up for her lunch. In addition, she denied any dysuria. She had no rash, no joint pains. She told me that 2 months prior to the admission, she had a C-section. She delivered a baby girl. More history, she's reported she drinks coffee 3 times a day, and she doesn't usually drink a lot of water. She consumes a lot of tea and lemon juice. She denied any alcohol use. She doesn't, smoke tobacco. And the past medical history includes asthma and in the C-section. Past surgical history includes the C-section. Medications, only medication she takes is albuterol when needed for asthma flare-up. Family history was reviewed. There was no history of cancers. Non-contributory, that's all, no history of cancers. Social history, she lives with her husband and the 3 children. She recently had a baby. Her family is very involved taking care of her child. No history of alcohol intake, no history of tobacco use, no IV drug use. No allergies. Vital signs. She's afebrile. Temperature was 36.9. Heart rate 71. Respiration rate 15. Blood pressure 120/80. On the exam, she's well appearing, not sick, well appearing. She's alert oriented. HENT, there's no exudates in the throat. On the cardiac examination, S1, S2 were heard. There were no murmurs. She was not tachycardic. In the respiratory, there was no crackles. There's no wheezing. On the abdominal exam, she's positive for Murphy sign. There's no guarding. There's no guarding. There's no distension. No rebound. Neurologic examination, alert oriented, no focal defects. Motor sensory intact. Extremities and skin with no rash present. I'll pause there. Thank you.
Fantastic.
Thank you, Ravi.
Maybe Vale, if it's okay with you, I'll talk just briefly about the rest of the HPI, and then I'll leave the vitals and the physical exam to you.
Perfect.
Awesome. Alex, I see that you're asking also two very important review assistance questions. Do you mind unmuting and sharing a little bit more about what you were thinking with the constipation and the obstipation questions? Oh, no worries, no worries. Ooh, and then Dana bringing up a brilliant point here with the history of the C-section. Dana, are you in a place where you can unmute and share a little bit more about how that's altering your differential here?
Yes. Hi, everyone. So I'm thinking with the history of C-section, 2 months, it's it could be adhesions, especially with the nausea and vomiting. Could be a sign of small bowel obstruction. I was looking for something on the physical exam to show like abdominal distension or maybe on percussion, but there's nothing about that. The Murphy sign though is making me think about acute cholecystitis, but again, the vitals are not congruent with that.
Awesome. Thank you so much. I love the point, right? So we sort of have this new background information that's informing the foreground with the history of the surgeries, increasing our pretest probability of there being potentially adhesions contributing to an SBO. And I'll sort of talk briefly about a couple of the other elements of the history that we got. And I think one of the things that is really striking to me is the fact that the pain is worse with inspiration, or it's coming to the point where it's leading to the development of shortness of breath. And I think whenever I hear like that sort of description of it's either worse when I take a deep breath in or I can't take a deep breath in because it hurts so bad, it invokes the sort of a pattern of pain called pleuritic chest pain. And I think pleurisy usually localizes us into the thoracic cavity, which is really the question of like, what are the lungs potentially touching when we take a deep breath in, right? And that could be the pleural space itself, if there's fluid or air in the pleural space. It could be the pericardium if there's underlying pericarditis. It could be related to a pulmonary parenchymal process as the lungs themselves move and potentially irritate the parietal pleura, and that could be from something like a pneumonia or a pulmonary embolism. But there is a forgotten friend of pleuritic of the syndrome of pleurisy, and that forgotten friend is the diaphragm. And so the diaphragm, if that gets irritated, can also lead to worsening pain when we inspire, because the diaphragm has to contract and move whenever we take a deep breath in. And so then the question becomes, well, how can the diaphragm get irritated? And it can get irritated from something above or below. The above causes are all the things that we mentioned, parenchymal processes or pleural processes, or rarely a pericardial process if the person has a very big heart. But then there's also the things below. And so if we're dealing with a process below on the right side, that brings again the potential hepatobiliary system into the fold. Or if we're dealing from something below on the left side, then it potentially invokes the spleen. Both of those can lead to diaphragmatic irritation. it's a bit of a geeky point, but if there's any group that's down to get a little bit nerdy, I feel like it's the crew that's here on VMR. Where the diaphragm is irritated will influence where the pain manifests. And so the outer portion of our diaphragm is basically innervated by visceral nerves, and so we'll feel that that visceral irritation within the sort of like upper quadrant area itself. Whereas the central part of the diaphragm is innervated by a different set of nerves, and that is and that will refer pain up to the scapula. And so if you have outer diaphragmatic irritation, it may manifest locally, whereas if you have inner diaphragmatic irritation or in the center part of our diaphragm, then it may refer pain up to the scapula. In this case, it seems like our center of gravity is within the abdominal compartment, and potentially something in the abdominal compartment that's butting up against the diaphragm, but I'll kick it over to Vale to take us more through what the exam is telling us about whether or not that hypothesis plays out.
Yeah, sorry, that echo must have been horrible. I'm on my phone now, sorry, my Wi-Fi was totally failing on me. So yeah, Jack, I love what you mentioned. And I was actually also thinking about patients with a C-section past medical history. So I love that idea by Dana as well. And yeah, well, I think the positive Murphy sign obviously makes me think about the cholecystitis. And I think with the pattern of vomiting after eating and the epigastric pain could also fit in that illness script. But I'm definitely still worried about the possibility of something, well, not really because the vitals are very reassuring, but just because of the abrupt onset and the intensity of the pain. And so I think I would still want to rule out cardiac causes, but with a Murphy sign, I will go. And now that I think about it, I was also thinking about maybe some complications of some gallstones probably over there, like that could explain this abrupt pain, like maybe an impactation of a gallstone and that causing inflammation or a fistula of some sort. And I was looking through the chat and I love Jasimran's idea of pregnancy associated gallstones, as well as Franco's suspicions of a PE, even though, well, there's no signs of the shortness of breath being associated with some pulmonary focal process, but we don't have the saturation yet. So maybe we can pass the mic to Franco if he can share his thought process. Okay, Franco is like me. Wi-Fi is failing all Peruvians today. So maybe Yasimran could share what he's thinking with the association with pregnancy and gallstones.
Oh, yes. So I think that should be more towards during the pregnancy, because in pregnancy, we have the increased level of hormone of progesterone, and progesterone can cause the delaying in the gallbladder emptying, which it releases. So that is one of the risk factors that increase the stasis at the level of gallbladder contents, and it can saturate again and again and lead to the formation of cholesterol stones. And cholesterol levels are thought to be raised in pregnancy as well. So I was thinking might be the process started during the pregnancy, but it wasn't, the whole phenomena of stone formation wasn't that evident during the term of pregnancy, but it continued after the pregnancy as well. Because I would say when we read about the gallstones, we read 5F, and one of those 5Fs is being female. So it is more predominant in female. Similarly, I have put, so that was one thought regarding that gallstone can be there. That the process started during the pregnancy. And the second thing regarding Valley, as you said, so we won't exclude the chest pain here, because I always read there are 3 atypical signs of chest pain. So the 3 areas, if it is a female gender, a patient has a diabetes, or if it is elderly, the chest pain can present atypically. And by that, I mean that it may present as epigastric pain. So obviously that I will keep in mind, the causes of MI or any kind of underlying cardiovascular cause.
Thank you, Josie and Bram. So maybe, Ravi, could you give us a little more of the labs?
Yes, I'm more than happy to give more lab data. Lipase level is 3,000. ALT is 1,200. I'm sorry. ALT is 120. Lipase was 3,000. ALT 120. AST 60. Alk phos 150. And all other lab data, like WBC count, hemoglobin. Okay, I can just tell you the numbers. They're all within normal range. WBC is 5.0, hemoglobin 13.2, platelets 237, glucose, creatinine, sodium, potassium, they're all within normal numbers. And urine analysis, our urine UA specific gravity is greater than 1.030, negative for nitrous, negative for leukoesterase. She's not pregnant. HCG is negative. And radiological data, we obtained CT of the abdomen. CT of the abdomen results include impression is cholelithiasis, dilated gallbladder, and extrahepatic bile duct. Right upper ultrasound is recommended. And small non-obstructing right renal calculus. And next ultrasound of the abdomen found. Oh, actually, I'm sorry. They didn't obtain the ultrasound. We went MRCP after that. And the impression of the MRCP, there's no ductal dilation or filling defect. Suspicion for cholecystitis. That's all. Thank you.
Robbie, can you repeat the right upper ultrasound again?
I'm sorry, she didn't obtain the right upper ultrasound. She did not obtain it. They went straight to MRCP. The team just did not.
Got it.
Yeah.
Amazing. Well, rich data. Vale, I'll leave it to you to sort of take us through the findings that, the findings that we have here. As just Imran mentioned, acute pancreatitis has entered the chat. We can welcome acute pancreatitis, and I'm super excited to hear what you're thinking.
Yeah, definitely. I think we maybe had been played a little bit by the Murphy sign. I wanted to ask you actually, like, I didn't know exactly how big of a predictive value it had for acute cholecystitis, even in the absence of fever. And I was looking it up, and it has a very broad sensitivity and specificity. So I think that's something that we'll keep in mind for future cases. And yeah, the very, very, very high lipase makes me think about acute pancreatitis as well. The presence of gallstones, then again, could be an incidental finding, as well as could be part of maybe the process itself, like an extra hepatic obstruction that could also affect the pancreas. And so the fact that there's a dilated gallbladder, an extrahepatic bile duct, okay, so there's an extrahepatic probably obstruction as well. So I think for this case, I'm actually a little bit uncomfortable, so I will ask for help. Jack, what will be your next step?
I think that your reasoning has been flawless, including linking in the Murphy sign to a potential underlying hepatobiliary pathology. I don't think that the gallbladder is necessarily off the hook yet as the ultimate cause of all of this mayhem that has happened intra-abdominally, even in the absence of overt findings of cholecystitis on our exam and imaging thus far. I'll sort of take us through briefly. Maybe Kelly, if I could take over the screen for just 1 second. I'm going to share something with the group here. Let me see. Can everybody see this schema here? So I think if we just think about, right, like as Jasimran mentioned, right, we have made a diagnosis of acute pancreatitis. There are 3 primary causes, or that there's 3 diagnostic criteria that can buy someone a diagnosis of acute pancreatitis, and we just need 2 of them. Those 3 criteria are compatible abdominal pain, which is usually upper abdominal pain that radiates to the back, an elevated lipase 3 times the upper limit of normal, and or imaging findings that suggest pancreatic inflammation. In this case, with the abdominal pain and the lipase, we're there. So then the question becomes, well, what is the potential underlying cause of pancreatitis? And if you want to have a sort of simple pocket schema, you really only need to remember 3 causes. And that's going to be gallstones, alcohol, hypertriglyceridemia, and then there's everything else. If you want to make that even simpler and just remember 2, you can just remember gallstones and alcohol over everything else. And so the reason that I think that your initial thoughts, Vale, were absolutely spot on, in addition to everybody in the chat who invoked the possibility of gallstone, is that gallstones can cause pancreatitis, or maybe I should say it this way. Gallstones can reveal that they are the cause of pancreatitis in a couple different ways. Sometimes they're right there in front of us and they're sort of stuck within the pancreatic duct or the bile duct, and they're saying, hey, everybody, look at me. I'm the thing that's causing this pancreatitis. But more often than not, they're sneaky. They try to cause pancreatitis and then duck away before we can find them, but they're not quite sneaky enough, and that they oftentimes will leave a trace. And what that trace is can sometimes be some of the things that we see on imaging here. If we were to think about what can happen when somebody has gallstones that end up causing pancreatitis, what happens is that those gallstones leave the gallbladder, they go into the cystic duct, and then into the common bile duct, and then they make their way down and will get stuck right before they make their way into the duodenum. They'll get stuck at the ampulla of Vater or the sphincter of Oddi. And when they're stuck there, what ends up happening is that things in the pancreatic duct back up and things in the biliary system start to back up. And when things in the pancreatic duct start to back up, those enzymes leak into the pancreatic parenchyma and they cause havoc, and they can cause pancreatitis and destruction there. But then they also, again, we have some biliary tract obstruction, which will give us an extrahepatic bile duct dilation, as well as sometimes a transaminitis, because when the biliary system backs up, the liver gets a little bit angry too. It's like, why are you guys causing this traffic jam? And it gets irritated in the same ways that I get irritated if I'm in a traffic jam. And so in this case, even though we don't overtly see gallstones on the CT scan, there is some suggestion that maybe there is a trace that gallstones were once there. And as everybody, or as multiple people have alluded to here, we have underlying risk factors for there being gallstone disease, as well as a syndrome that's not incompatible with biliary colic. Because as you mentioned, Vale, the right upper quadrant abdominal pain and Murphy-Stein suggest that maybe there was something happening within the gallbladder or the biliary tract. And so while we haven't necessarily made that clinching diagnosis, the fact that gallstones are such a common cause, and that we have signs of there being maybe a trace of gallstones having been there based off of the imaging findings, I'm right there with you and thinking that the gallstones are potentially leaving us on the hook here. But we have to be open to the fact that maybe it's actually not gallstones after all, in which case then we sort of start to do a bit of a detective journey and say, okay, is there potential underlying alcohol use? Is there potentially another underlying cause of pancreatitis that's causing biliary obstruction? Because as you astutely picked up, Vale, biliary obstruction is sort of coming into the chat as well, because we have the dilated extrahepatic bile duct. And so that could be something like biliary sludge, which just means that the gallbladder isn't contracting, things are slowing down, and that sludge can sometimes clog up the biliary tract system. There may be an ampullary mass, which would be a mass at the ampulla of Vater, where the pancreatic and common bile duct empty into the duodenum. And then in rare circumstances, we have what's called sphincter of Oddi dysfunction, which means that that ampulla doesn't open correctly and can get super backed up and blocked. And so, right, the MRCP is pretty sensitive for picking up the mass, but it's not perfect. The CT scan is pretty sensitive for picking up the mass, but it's not perfect. Biliary sludge is notoriously difficult to pick up, and maybe the ultrasound will help us there. And then sphincter of Oddi dysfunction is sort of oftentimes a diagnosis of exclusion. But at this point, I would say that like gallstones are still very much on the hook. And if those aren't there, then I think we have to look for alcohol, look for hypertriglyceridemia, and then further investigate the potential obstructive etiology as well. I see Sylvia mentioning the great point that if a stone is stuck, there would probably be a filling defect on MRCP. And Sylvia, you are 100% correct. We may actually be catching things after the stone has already passed. And so the stone is actually gone, but the bile duct dilation hasn't had a chance to normalize. And so sometimes we can see the signature of gallstone disease, but the gallstone has actually already made its way into the GI tract and is on its way out. But once the gallstone has done the damage of causing pancreatitis, the damage is done and we have to sort of deal with the consequences of it, which is treating her through her pancreatitis. So that sort of is where my head is at from sort of a probability standpoint. So I think, Vale, like your initial analysis that like it seems like we're dealing with something related to gallstone disease, I think is spot on and totally compatible with the finding of acute pancreatitis here.
Thank you. Great discussion. So final diagnosis was gallstone pancreatitis. The hospitalization course, she went through lap cholecystectomy. After lap chole, she tolerated a diet and she was discharged home.
Thank you so much.
Thank you so
Robbie.
much, Robbie.
Vale, I would love to hear some of your reflections on the case, but I just want to highlight again Sylvia's question of like how hard it can be to decide whether it is gallstone pancreatitis. I am a generalist and a very inexperienced generalist at that. And so I'm curious, Ravi, if you could teach us about how the consulting team sort of came to the diagnosis of feeling like it was gallstone pancreatitis, even when they didn't necessarily see a stone.
Yeah, thank you. Yeah, so the team have consulted gastroenterologists. The GI team, as you alluded, they said stone might probably have passed. And she has given the evidence of LFTs, ALT, AST were elevated, and alk phos were elevated, and her lipase 3,000. The gastroenterologist determined she probably had gallstone pancreatitis, and the stone had passed.
Thank you so much. Vale, I'd
Thank
love
you.
to, yeah, I'd love to hear reflections from you on the case.
Yeah, thank you, Jack. I loved your schema and your explanation on pancreatitis. I also wanted to thank Ravi because his presentation was amazing, and for it being super like you totally saved us because we didn't have a case, and after this case I feel like I've learned a lot and I have a lot to reflect. So first of all, I think the important part at the start was thinking about life-threatening causes of abdominal pain, and also I live with an schema of postprandial pain, which, as Jack alluded, could include a pancreaticosis, stuff affecting the choleric system or like the biliary tract. Also, you mentioned ischemia as a possibility, and I have to review that because I love your approach on postprandial pain. And then the thinking about like the Venn diagram of not only causes of abdominal pain that could be related to pregnancy as adhesions, but also the possibility of risk factors to forming gallstones that people related to progesterone. And that all together with the Murphy sign finding and the imaging and labs was a really good and classic presentation of pancreatitis. So thank you so much, Ravi. It was a really good learning case.
I love your reflections, Vale. Thank you so much. I think there's a couple awesome questions coming in through the chat. Alex asking about why or whether or not they felt the need to do the lap chole urgently. Ravi, I think that this is a great question because the timing of lap chole in somebody who has gallstones plus pancreatitis, I think is up for debate. I certainly, as an internist, would never feel comfortable sharing about like what I think surgeons should do. But I'm curious, Ravi, if there was any thought about whether or not it was urgent or just convenient to do it that admission. Ravi, do you happen to know?
I think we lost Ravi. Maybe he's in service or something.
Yeah, maybe he got called into something. But yeah, so I would say like my often reflex is once somebody has pancreatitis plus gallstones, like if someone has pancreatitis and we see gallstones, even if gallstones aren't the underlying cause, the gallbladder should come out because they're at risk for developing future episodes. And so I think in those cases, the timing of it though, or in those cases, the gallbladder should come out eventually. I'm not sure on exactly what the timing is. And then in terms of the question on when is MRCP indicated in acute pancreatitis, Param, that's a great question. We sort of have like three tools. We have ultrasound, CT scan, and the MRCP. Oftentimes what will happen is that the CT scan will can pick up gallstones, as it did in this case. And then if we have the CT scan but don't have the sign of gallstones, it sort of is dealer's choice of do we go for the ultrasound or do we go for the MRCP? If the ultrasound doesn't show stones, sometimes it's hard to necessarily settle on there not being stones, particularly if there's no other cause. And so then we'll go for the MRCP. And in some cases, people just go straight to the MRCP from a diagnostic efficiency perspective, because it is a very, very sensitive test. And so I think like, I haven't been able to discover for myself a specific rhyme or reason around like which order to do which things, because sometimes people don't get a CT scan up front, then we go for the ultrasound to see if there's stones. Other times we go from the CT scan straight to the MRCP, but those three tools, ultrasound, CT, and MRCP, can be helpful tools to look for not only the presence of gallstones, but other underlying hepatobiliary pathology like strictures or masses, which are all going to be on the DDX in any case of acute pancreatitis, but particularly when we see biliary ductal dilation. I'm not sure if that just makes things more confusing or not. And just Imran, yes, that is absolutely correct. If we see that there's something obstructing the biliary system, then we have to relieve that obstruction, and then the ERCP is going to be the most, or at least asking our GI colleagues to consider doing an ERCP. They will be the final decision makers, but that is usually the trigger to think about an ERCP, is if we have an identified source of biliary obstruction, whether that's a stone, a stricture, or a mass. Oh, Brody, tell us more in terms of UWorld putting ERCP first. Are you in a place where you're able to unmute?
Well, yeah, but I can't share my video. But I felt I was doing I'm studying for step 3, and and one of the things I realized that their questions are very prototypical. That is gallstone pancreatitis, but they kind of say ERCP first because I think you get less radiation, and they say that it's both therapeutic as well as diagnostic. So, so in a way, you kill 2 birds with 1 stone, and I don't want to kill any birds. I'm not. Don't hold me on that, but yeah, that's what my 2 cents are.
Thank you so much, Brody. This wasn't just Robbie. I cannot thank you enough. I echo Vale 100%, and what a brilliant case this was, and really held the tension of like, I think it really highlights that like a final diagnosis may be a common diagnosis, but cases are seldom completely simple, and there was like so much learning and so much of a rich discussion to be had here. So thank you so much. And then Alex asking, any chance that was more for Alex? Are you saying was the MRCP more for cholangitis, or are you saying ERCP? Yeah, that's a great question, Brody. Was that in the setting of cholangitis rather than gallstone pancreatitis, or do they say for gallstone pancreatitis, where there's an ongoing obstruction, go straight to the MRC or go straight to the ERCP?
I know that it was gallstone pancreatitis. Cholangitis, they said it's inflamed duct. You probably wouldn't want to tamper with that at that particular time. So I was pretty sure the question was gallstone pancreatitis. That I'm sure of.
Yeah. And I think it's totally reasonable, right? Like if we have a clear diagnosis of like there's a gallstone that's clogging it, if we can make that diagnosis without imaging, without a CT, which sometimes we can do with the ultrasound alone, then it's reasonable to proceed to ERCP. In my experience, oftentimes these patients with acute pancreatitis end up with a CT scan anyway, and so that can sometimes be the thing that we end up giving them some radiation before the ERCP. Actually, I love it. We're sort of getting the UWorld tips and tricks here. This is awesome.
No, that's really funny. Yeah.
I would say it's totally plausible, right? Like if the CT in this case had showed acute obstruction of the biliary tract, then going to ERCP, And that's a very common and totally reasonable diagnostic pathway to follow, and one that I think very often happens in cases of anybody who has biliary obstruction and acute abdominal pain. The CT is often step one, and then we decide where to go from there. But yeah, this is an awesome discussion. Vale, any other final reflections before we turn it over to Deborah for the teaching points?
No, thank you so much for the teaching. It's been great. So take it over, Deborah. I love your teaching points.
Hello, everyone. My teaching points are a little bit too small. Yeah, talking about the abdominal pain, we gotta think if the process is in the abdomen or outside, and we gotta think of pancreatic, biliary, vascular, or if can be outside like cardiac, pulmonary, or like kidney, and as is a woman, an ectopic pregnancy. And the diaphragm can be irritated, so we have to think above the diaphragm and below. Above, we can think about parenchyma and pleural, and below the right, in the right side, the liver and the gallbladder, and the left, the spleen. And to do the diagnosis of acute pancreatitis, we have to have 2 of 3, that is abdominal pain, image, and elevation of lipase. And then the schema that Jack showed to us, he signalized the 2 most important causes that could be gallstones and alcohol. And the gallstones can be in the pancreatic duct or in a biliary obstruction. And then something interesting that I thought that was like that it can still have sign of gallstone disease, even that stone is not there. So yeah, that's it, everyone. Thank you for being here.
Thank you, Deborah. That was amazing.
Thank you so much, everyone. Thanks again, Ravi, Deborah. Thank you for everything. And Kelly, thank you for the excellent Friday. See y'all later.